I do love 3A. I like 3A, especially surgical 3A, because there's no right answers. There's lots of wrong answers maybe, but no right answers. And there are lots of zealots. People have really strong opinions on how to treat 3A, and not that they're not right, but I think there's lots of options. So my ERS question, I don't have clickers, but I'll just take a raise of hands to see where we are in the room about the treatment of 3A. So at your institution, a fit person comes in, we've identified what looks like potentially resectable N2 disease on their pre-op screen or their pre-treatment imaging. Whose institution would be treating this patient with definitive chemotherapy and radiation alone? Hands? Not that many. What? Oh, come on. How about induction chemotherapy alone and then possible resection? Again, a smattering. Chemo RT to 45 gray and then evaluation for resection? Wow, that's our biggest group. How about to 60 gray and then evaluation for resection? Cool. What we usually see is a pretty good smattering between all of those, and that's probably appropriate. Obviously, I think 3A is one of the therapeutically most challenging, and that's because we treat these patients for cure, but cure is pretty elusive. All these patients should get chemotherapy because their real risk is for systemic disease, but we do need local regional therapy if we're going to cure them, and how that fits between surgery and radiation is really unclear. I think part of the problem in stage 3 is that it's this huge, huge stage that's full of all these different subsets. As a surgeon, I like to put things in little boxes, and these are kind of my little boxes for stage 3. They're the non-N2 patients, which are typically treated like stage 2 patients. There are the 3B patients where I can go to sleep in tumor board because these patients really shouldn't, in most cases, be treated by surgeons. And then there are the N2 patients who are the kind of most interesting. We're going to briefly take a look at the non-N2 patients. This is a pretty small subset of 3A disease, and these are mostly large, aggressive local tumors with either no nodes or just N1 nodes, and this also includes the superior sulcus tumors. For most of these patients, treatment is very much not like the N2. In fact, if you go to the ACCP guidelines, they're not even in the stage 3 chapter. They get put into a special chapter because somehow the pulmonologists don't even see this as stage 3 disease. But NCCN does a pretty good job of telling us that these patients should probably be treated like stage 2, and based on consensus alone kind of data, they recommend upfront surgery followed by resection. And results of resection for some of these can be fairly good. Again, most of these are big tumors, but N2 disease here is a contraindication when you have a T4 tumor. I think what's important is that for these large tumors, it really does take a surgeon to tell you who's resectable and who's not. We have lots of new toys every day, and therefore, lots of pieces of spine and heart and aorta, which used to be unresectable. Suddenly, it's a little bit easier to get those pieces out. But we're definitely not going to treat any of these patients up front with radiation. The real question becomes in some of these is, should it be adjuvant or neoadjuvant therapy? Those that argue for neoadjuvant says this is what we do for the rest of 3A. This is what we do for superior sulcus tumors. Why aren't we doing it here? And could this help make people resectable? Those who believe in adjuvant say that you probably will miss the window for resection. Maybe chemo works best if there's just a little bit of disease left. And finally, there's not a lot of randomized data. I think it goes both ways. I mean, the LACE meta-analysis is our best data about using adjuvant therapy in this population because there were 3A patients there, but none of these were T4 tumors. Again, N0 patients, those big T4, T3 N0s was not really what this analysis was about. The issue of compliance is a real one in this population. So we're talking about big operations. A lot of these are going to be open operations. A lot of these are going to be pneumonectomies. Compliance in patients who undergo pneumonectomies is poor. Compliance in the elderly who get adjuvant therapy is poor, and anyone who has surgical complications. Those are all risk factors for not being able to complete your adjuvant chemotherapy. So if you think that chemotherapy is important, you might want to be giving it up front. This is similar data from the JRB trial looking at those same issues, but pneumonectomy and complications as major risk factors for not being able to complete your adjuvant therapy. So in our group, we always talk about people who we think are going to get a pneumonectomy even when they're N0, because they might want to get their chemotherapy beforehand. So the non-N2, again, evidence is a little bit weak, the group is a little bit small, but it says that resection plus adjuvant is what's recommended, although a lot argue against it. Careful selection is essential, and compliance with adjuvant therapy is usually poor. So I think the most interesting group is the N2 group. This is the majority of 3A patients. This is where the best arguments seem to lie. But even within the N2 population, this is still a very heterogeneous group of patients. It is very much the bulk and extent of the N2 disease that tells us how we should be treating these people. In those who have occult disease, we talk about surgery up front, to those who just get palliative treatment for what's considered unresectable disease. This is one of my favorite figures that kind of goes over how we gotta go through these and where the treatment decisions are made. N2 disease from a surgical standpoint goes into 3 groups: occult, potentially resectable, and unresectable. Surgeons, we like boxes. So occult or unforeseen N2 disease, this is the patient, not the patient who got a CT scan and then went to surgery. This patient has been fully staged. They got their PET, they got their CT. If they had a big bulky central tumor, they also got their EBUS or their MEAD, and they didn't see any N2 disease. We go to surgery, lo and behold, after a nice lymph node evaluation, there it is. Again, very different than we didn't look for it. And these patients have a good outcome, and adjuvant chemotherapy is appropriate for this group. The bulky infiltrative or unresectable N2 disease, there's nothing I can do at surgery to make that person resectable. No chemotherapy, no radiation is going to make a tumor like this resectable. I think as surgeons, we have come to realize that this is a place where we don't have a role, and that you can't make these people resectable. And I think it's important to make that decision up front. Hence, then we get to the potentially resectable N2 population. So ipsilateral disease that's discrete, has stayed in its nodal basins, and can be resected, because debulking doesn't help. If we're going to do anything at surgery, we have to get all the disease out. And what happens here now is based on a lot of things. This is where your patient's performance status, your institutional biases, and the number of involved nodes seems to come into play. These are kind of some of the basic surgical questions. We'll try to just touch on them. Should surgery ever have a role in 3A? What's the best type of induction therapy? Should pneumonectomy be offered as part of 3A? Should patients who have residual N2 disease after induction therapy still get resection? And can we identify those patients who are the good and bad players, those who should or should not be taken to resection? So we'll start with surgery have a role at all in 3A. Those who believe it does, believes that the majority of patients who undergo resection after induction therapy have residual tumor, that surgery provides better local control, and that helps survival. The con is it doesn't come without morbidity and mortality, and the evidence supporting improved survival isn't strong. Part of who decides it is who do you ask? These are 2 independent studies, one asking medical oncologists and one asking thoracic surgeons, does surgery have a role in 3A disease? So if you have single station or microscopic disease, most people agree there's a role for surgery. Once you get into multi-station or clinical evident disease, suddenly the medical oncologists have a lot less enthusiasm than the surgeons. And if you ask a surgeon, there are few who ever believe we don't have a role in 3A disease. Old studies say, sure, chemo versus chemotherapy, definitive with or without surgery. These were never very impressive. There were lots of old randomized trials, but they had old staging, old agents, and the results were never very impressive. The intergroup trial is really the trial that was designed to answer this question and makes up most of our modern understanding of resection for 3A. It was a randomized trial, 430 patients, and it was supposed to tell us for sure. Definitive chemoradiation versus the addition of surgery. Unfortunately, although it was a well-run, well-done trial, all it did was muddy the water here. Surgeons thought it convinced them that surgery had a role here, and medical oncologists felt, no, we've proven there is no role here. But it did get us into the direction of what questions to ask next and who should be offered surgery. This is a nice retrospective series out of the University of Toronto looking at this question retrospectively. They went back and looked at over 700 patients at their scans preoperatively and at their performance status comorbidities preoperatively, and found a group that was matched with who had undergone chemotherapy and radiation who could have been offered surgery, and those who underwent chemotherapy, radiation, and went to surgery. And you can see that the surgical group did significantly better, even though they were matched for things like performance status, histology, nodal stations, and such. But retrospective data is retrospective data. Prospectively, there was a new trial out of Europe which tried to answer the question again. It looked at cisplatin vinorelbine, reassessing patients, and then randomizing them to either a definitive booster of radiation or to resection. They had tried to randomize like 800 patients and somehow only ended up with 160 because of poor response to the initial therapy, but clearly didn't show a difference, but also closed early, underpowered, and had many issues. So the question remains, next, induction chemotherapy or chemoradiotherapy? I think the strongest zealots live in these camps. This is where people get really emotional and swear that their way is the best way. So those who believe in tri-modality therapy, I think correctly believe that path CR and mediastinal nodal clearance are currently our best markers for overall survival, and probably are appropriate that path CR and mediastinal nodal clearance are higher with the addition of radiation to an induction chemo routine. They do see better rates of local control. Those who are in the bimodality camp agree with them about the chemotherapy and radiation giving you the best survival, but recognize that it really hasn't flushed out to overall survival in any randomized trials. They believe radiation adds complications, and that really it's a systemic response to chemotherapy, which is the driver of survival. I think they're both right. This is a recent meta-analysis that came out looking at these things, 12 trials, 2,700 patients, and again, some of the things we talked about. Adding radiation does result in better downstaging, better mediastinal nodal clearance, and more path CR and better local control. Unfortunately, it does not necessarily turn out to be better overall survival, although I would tell you that both of those diamonds look like they are leaning toward improvement on with surgery and radiation compared to surgery and chemotherapy alone. This is really interesting work, though, from, oh, I'm sorry, I forget. This was another trial. This is a recently finished trial out of Europe also designed to answer this question. This is the Swiss trial, which looked a prospective trial of 230 patients, only open at experienced surgical centers in Europe. They looked at sequential chemo plus radiation to 44 gray, and then they were randomized between chemo and radiation alone. The treatment was well tolerated. Surgical morbidity and mortality were excellent, 1.3% mortality in these patients. There were many, many pneumonectomies and extended resections. That wasn't the issue, but there was really no improvement in survival with the addition of radiation. But we also didn't see the nodal downstaging and path CR that we typically see with concurrent chemotherapy and radiation preoperatively. So a lot of people argue that maybe that sequential delivery wasn't really giving us the appropriate bang for the buck. And next, what radiation dose is best pre-op? This has become a new discussion and one that RTOG has been pushing forward because they do kind of believe in the higher dose. So 45 gray or 60 gray. 45 gray, sure, it's what we use for most superior sulcus tumors. Increasing doses should increase surgical complications. Those who believe in 60 gray believe that we will get better clearance for 60 gray and that there's really no evidence of increased complications. The complication one, surgeons seem to have this great fear of 60 gray, which I agree, I don't think is particularly well founded in any of the literature. This is work from the Mayo Clinic looking at their comparison, single institution, of 45 gray versus 60 gray. And what they found was that, yes, toxicity was higher with 60 gray, but that was all the pre-op toxicity. There's a lot more esophagitis with 60 gray. Surgical toxicity, there isn't real differences. And we found the same thing in our RTOG trials. So I don't really think that that argument is very legitimate. This is an interesting argument, though. This is recent work from the Swedish group looking at their experience with 45 and 60 gray. And what they found was that in the patients who got 60 gray, again, higher path CR, higher mediastinal nodal clearance, they saw slightly higher surgical morbidity, but not mortality. Amazing, the cancer-specific survivals were similar. But look what's different. The people with a higher radiation dose had more delayed non-cancer-related deaths over the next 5 years. So this is a little bit like what we're learning about definitive chemoradiation therapy in stage 3, that it may matter where we're giving that radiation. Were these all left lower lobe tumors? Is this radiation dose to the heart? Many of these were cardiac events in the group that got the higher. Again, not a randomized trial, but very compelling evidence that there may be something here that we have to tailor our preoperative radiation a little bit better if we're going to give higher doses. Should patients with residual N2 disease after induction therapy get resection? This is an argument we have at our meetings all the time. Those who believe that yes, or those who say we can't really know who's going to have residual disease unless there's a biopsy. Repeating mediastinoscopy is dangerous. I'm not going to put my patient through it. And surgery is better than the other options that these patients have. Those who say no resection, and there are some strong people who believe that the risk of surgery is not justified by the potential benefit, and that you actually can rebiopsy these patients now that we have EBUS in our armamentarium. And the way that you would do these patients is you need to EBUS them up front, then you treat them, and then you do your mediastinoscopy. Because the value of EBUS is lost somewhat after induction treatment. They really don't feel that their biopsies are as reliable and as easy to do once someone has been treated. My argument on this, and I do lean toward resection in this group, is that really with that, the resection's better than nothing. The reality is if you look at the patients who are positive after chemotherapy and radiation, we expect their survival rate to be in the teens. 14, 16% is really what I quote my patients. But the reality is without surgery, their survival rate is in the single digits. We're talking about 5, 7% at the most. So I always, if the patient has remained fit, go along with what we determined before treatment as long as they have not progressed. Should pneumonectomy be offered? Again, very controversial. Pneumonectomies after induction therapy are something we argue about all the time. There's many single institutions trials that report acceptable morbidity and mortality, and a lot of people think that pneumonectomies and their complications is all a matter of surgical inexperience. But the reality is there's lots of multi-institutional studies that should quote mortality somewhere around 20 to 25%. This is what kind of killed the intergroup trial from a surgical standpoint. Patients who got lobectomy had a 40% overall survival with the addition of surgery. That's great for 3A. But the pneumonectomy group did terrible. Up to a third of the patients in this trial got pneumonectomy, and the mortality was 18%. That's too high. Any trial that gives you 18, any group with that high of a surgical mortality is never going to do well. We thought this was because people weren't experienced. So right, the high rate of pneumonectomy may have been poor surgical judgment, but the 18% mortality, it's hard to know. This is a meta-analysis looking at chemo versus chemo-RT and mortality from a pneumonectomy. About half of these trials are trimodality, and you can see all the risk factors, right-sided lesions, low volume centers, and things like that. But the reality is the rates are high, 7% at 30 days and 12% at 90 days. This, I think, is real. These patients do not do well. The reason I think this is real, I just looked at prospective data from 2 RTOG trials looking at the surgical response after chemotherapy and radiation. 93 resections, the grand majority by lobectomy, 1.3% mortality for lobectomy, and 18.8% for extended resections. That's at 90 days, not 30 days, but still very high. Can we identify who's most likely to benefit? These are easy. Minimal N2 disease, They do well with surgery, they do well without surgery. This is the group that should go to surgery. Many, many trials that tell us this group does better. Mediastinal nodal clearance, another huge marker for overall survival. Unfortunately, we can't identify it unless we actually take them to surgery. Other things we really look at, multiple trials are now recognizing either past CR or less than 10% viable tumors in the resection, but all of those are things that you find after you operate. The only strong data for what you should do before surgery is, again, the best prognostic marker is the one at the bottom. If the patient can be resected by lobectomy rather than an extended resection by lobectomy or pneumonectomy, that is a candidate who is in the better group. How do we operate finally? I always tell people carefully. These are not small undertakings. These can be big operations. You want to do it timely. You don't want to wait 3 or 4 months. You want a full lymph node evaluation so you can make decisions about further treatment. We usually put live tissue over our stumps, but this does not exceed a minimally invasive approach. Why quickly? Because we know after induction therapy, especially radiation, we will get fibrosis starting at about 12 weeks. This is work from the NCDB and the group at Yale saying that most patients get operated on within 6 weeks of completing their therapy, but the longer you wait, the worse overall survival. And then finally, minimally invasive approaches. As we get better with our minimally invasive approaches, this is more and more possible. The Duke group is an excellent minimally invasive group, and about a quarter of their induction patients are done minimally invasive without increased morbidity and mortality. And from the recent RT or G trials, we again saw about 10 to 15% of our patients attempted minimally invasively without any increase in morbidity or mortality from those resections. So we do think it's a way to approach these patients. So surgery for IIIA, it's still the bulk and the extent of nodal disease which dictates our treatment algorithms. Optimal role for therapy remains highly controversial. We know that past CR and mediastinal nodal clearance are our biggest predictors of post-resection survival, but we don't know what those are until the patients have them out. I still believe surgical expertise is important here. These are not small undertakings. We do need better prognostication to appropriately choose who goes to surgery, and the reality is all of this may change very, very quickly because of the introduction of checkpoint inhibitors into stage 3. Thank you.